person, which you will figure out very soon. But today I find it very difficult to put in words how grateful I am to the organizers for inviting me and how touched I am by Moscow itself. So thanks once again for offering me this opportunity to talk to you today. I also wish I could speak Russian to you, but out of my primary school Russian, I'm only left with "Извини, пожалуйста, прости, разреши," but I don't think it would be enough for today. I will be talking on behalf of the Food for Me consortium, and I will tell you a bit more about it during the talk. And I'm also representing an organization, European Food Information Council, and I will tell you what it is all about towards the end of the presentation. My presentation will not focus on science itself. It will focus on communicating about science. And I want you all to leave this room in the afternoon committed to communicate about what you do in such a way that people can understand. You can see the two Twitter handles beneath my name. I do expect you to use social media as a way to interact with the world. So starting from now. This audience does not need an introduction to personalized nutrition, neither a very thorough explanation of the parallel between the personalized medicine and personalized nutrition. The main difference is that it is not a pharmaceutical, it is a nutrient that affects the... Is it okay? Can you hear the translation? Okay, that affects the body. And one of the examples that you can think of are the omega-3 fatty acids. Also, personalized nutrition, unlike personalized medicine, in principle doesn't include prescriptions or doesn't ask for pharmacists. So there are a number of opportunities in the world of personalized nutrition. And when you put it together with all the electronic devices that we now have to assess our body functions, there is a universe of opportunities. So that is actually what the Food for Me project was set to do, to explore the opportunities, but also the challenges of personalized nutrition. It was a very good project. It was €9 million worth of financing from the European Commission. It finished just last year, and the publications out of this consortium are still coming out. It involved a number of beautiful brains from Mike Gibney that Jim mentioned this morning, over Ben Van Ommen, John Mathers, Michael Müller. So really wonderful work in this consortium. It involved 26 partners from 12 European countries. It was coordinated by the University College Dublin, and you can see the universities, the SMEs, and also the large companies and institutes that took part in this consortium. It looked into personalized nutrition from a number of different perspectives, anything from ethical and legal, over business models of personalized nutrition offerings, all the way to qualitative and quantitative consumer research, and it involved a large arm of human intervention studies. And, well, in Jim's terms, it was a combination of 20th and 21st century research. What I will focus on today will be the findings, only the top-line findings in very simple terms from two of the aspects of this research. One is the results of human intervention studies, and the other one is learnings from the qualitative consumer research on how to communicate about personalized nutrition. So the intervention study was set off to find out if personalized nutrition or if personalized advice really works. The working definition of personalized nutrition used in this consortium was that personalized nutrition is the recommendation of a dietary behavior appropriate for an individual to maintain optimal health. It takes into account the individual's dietary and lifestyle patterns and preferences, the phenotypic biomarker status, and genetic background, and it recommends on food choice, eating patterns, and lifestyle. And personalized nutrition is not the same as nutrigenomics. Nutrigenomics is a science of how foods affect our genes, on how our genetic makeup affects the way we respond to nutrients, and how this gene-nutrient interaction affects diet-related diseases. We live in the world in which is expected that 70% of deaths globally will be due to non-communicable diet-related diseases in 2020. The modifiable risk factors need to be changed, and quickly. And it seems that the current strategies and one-fits-all recommendations do not work. So the question was whether personalized nutrition could do better. The hypothesis of this work was that providing personalized dietary advice will improve dietary intakes and markers of health, including weight and waist circumference. The research questions were rather simple. Is personalized nutrition advice more effective than general healthy eating guidelines? Is phenotypic or genotypic information more effective than the diet-based advice alone? Does more feedback mean more compliance? And a rather technical one, is the internet a successful delivery method? Participants were recruited on the internet. The project was promoted in advance using different media and web-based challenge, so you can consider this study a web-based randomized control trial. The study protocol is detailed here. So interested individuals from all over Europe could register their details on the Food4Me website. And then they went through 2 screening questionnaires which enabled the researchers to assess demographic, health, anthropometric and dietary information. They also filled in a food frequency questionnaire to estimate their habitual dietary intakes. And all the individuals that were pregnant, lactating, following a prescribed diet, or having a food allergy or intolerance, or not having access to internet were excluded from the study. Then the individuals that were enrolled into the study again completed an online food frequency questionnaire, took themselves their anthropometric measurements. They started wearing physical activity monitors that were delivered to them by post, and they collected buccal swabs and blood samples and dry blood spot cards, which define the baseline for the study. After 3 months, the food frequency questionnaire was repeated again, and after 6 months, and blood samples were collected, and after 6 months, the whole thing was repeated. Participants were provided with a personalized report, which was based on their diet, phenotype, and genotype, regardless of their intervention arm. So the personalized nutrition advice was generated based either on diet and phenotype, and on all 3 of these aspects. So the participants were randomized into 4 different groups. Level 0, or first group, received a generic dietary advice without an insight into their habits. The level 1 received personalization based on their dietary analysis. The level 2 received personalization based on their dietary analysis and phenotypic analysis. And level 3 received personalization based on dietary, phenotypic, and genomic analysis. The primary outcome of the study was a dietary intake at month 6. The secondary outcome was physical activity and phenotypic markers at month 6, and in between we collected this information at month 3. In total, there were 1,600 Europeans that were enrolled in this study, most of them female, 61%, and with an age range from 18 to 79, with mean or average age 39.8. Almost 97% of the participants were Caucasian. If you look into their weight status, about half of the participants were normal weight, and the other half obese or overweight, pretty much reflecting the situation in Europe, and a small number of participants were underweight. And these are really the top-line results from the study. If you look into changes in energy intake at month 6, as expressed per kilojoule per day, you can see that the control group that received a general dietary advice has decreased their energy intake by about 1,000 kilojoules. So the very fact that someone is communicating a dietary advice to them has affected their behavior. Then if you look into personalized nutrition group, and this light blue bar represents all 3 arms of personalized nutrition participants, they decreased their dietary intake even more. However, there was no difference between the different arms of the personalized nutrition. So the diet and phenotype, or diet, phenotype and genetic information as a basis of the personalized nutrition advice did not make a difference in people's behavior. When you look into changes in red meat intake at month 6, as expressed in gram per day, you can see that the control group decreased their red meat intake, and the personalized nutrition group has decreased that intake even more. Again, no difference was established between the different levels of personalized advice. There are changes in healthy eating at month 6, as expressed by a healthy eating index, were obvious. So the control group improved their healthy eating index. The personalized nutrition group, again, significantly more so, and there was no major difference between the arms. So the take-home messages, very clear and simple ones, are that the personalized nutrition works. There is no added advantage that was found in this study of phenotypic or genetic information, and the internet-based delivery seems to be possible and effective. Now, how about the consumers? The Food for Me consortium has gauged the consumers' attitudes, or has organized focus groups and deliberative workshops to understand the public views on personalized nutrition and to provide guidance on communication on personalized nutrition services. The focus groups were organized in 9 different European countries, 2 focus groups per country, involving people of 2 different age categories, and this is where it becomes painful for me. So the age category of 18 to 65 was called adults, and the age category of 30 plus years old was called older. The contributors to consumer acceptance were perceptions of risk, benefit, and cost, and also trust in authorities and public service providers. Ethical and value-based concerns were raised about data protection and access to services, and they were seen as potential barriers to acceptance of personalized nutrition. And there were no major cross-national differences that could be observed between the focus groups. I will share with you the major concerns and perceptions that came out of the focus group engagements. So, first of all, what is personalized nutrition? To the participants, it was not clear what the personalized nutrition was, nor how could it help, especially when it comes to individuals with no underlying health issues. The speed of personalized nutrition delivered online was very much appreciated. However, older participants were hesitant using internet for personalized nutrition service, obviously due to technical challenges, and younger were more comfortable with an online personalized nutrition service. What I would like to stress here is that these people that took part in focus groups and the extended deliberative workshops did not take part in the study. They were random participants non-related to the study. The convenience of the personalized nutrition delivered via the post was appreciated. However, there was a mistrust in the reliability of postal service, especially when it comes to blood and the DNA samples. When it comes to the offerings of personalized nutrition by public institutions or by commercial providers, there was less risk perceived and more trust reported in a public health sector or a university or institutional provider. And major concerns were expressed over data handling and online security and safety. The concerns of passing individual health data to insurance companies, marketeers, or even employers were raised, and a personalized nutrition service administered by a local GP or a dietitian was seen as most trustworthy. Anonymity was seen as an advantage, and people thought that it would reduce the perceived risk and protect their privacy. Other concerns included trust. There was trust, but only up to a level. There was a concern about misuse of biological materials. Genetic testing was often mentioned as a step too far. And the competency of the behind-the-screen personalized nutrition individual was questioned. Some participants thought that personalized nutrition should be offered at no cost. The others, however, thought that having to pay for it would guarantee a good service. Then, related to psychological well-being, there was a fear of failure expressed here. Personalized nutrition services were associated with that fear, and participants believed that a strong motivation and willpower were necessary for the personalized nutrition to succeed. There was also a fear of truth. The participants were worried about discovering the diseases that would come out of the genetic testing. And personal contact was considered very important to motivate and to emotionally support. Having analyzed the results of the focus group, we then organized extended deliberative workshops in order to suggest the measures to highlight perception, lessen concerns, and improve acceptance of personalized nutrition. And also, we delivered some communication guidelines on personalized nutrition. I will not talk about the measures suggested here. You can find them as a deliverable of this project. And please refer to the Food for Me website. You will find all the publications still coming from this research there. I will share with you the communication guidelines when it comes to personalized nutrition, and I hope you will find them useful in your work. What we did is that all of the concerns and perceptions that I shared with you now were further tested in the deliberative workshop, and the participants of that workshop rated the 7 most important ones. And they found the most important concern, the trust in providers. So when it comes to trust, the communication guideline would be to clearly explain that the only purpose that the samples will be used for is the personalized nutrition analysis. Also, make sure to highlight the benefits and importance of genetic testing, communicate about science and technology as the sheer carriers of progress, and highlight that the service is administered by health professionals. Also, it's important to highlight the speed in which an individual can submit their details and then obtain personalized nutrition advice, and highlight the simplicity and convenience if you're providing the service via internet. When it comes to anonymity and privacy, make sure to explain that personal information will be anonymized, and clearly state why the protection of users' identity is of foremost important for your institution or for your business. When it comes to personalized contact, we better make sure to highlight the personal touch that is provided by the personalized nutrition service. We should reassure people that operators are an experienced and trained team of specialists, and we should provide the positive testimonials from other consumers. When it comes to fear of truth, we believe it's important to explain the risks to future health if no action is taken. We should provide reassurance that support is provided every step of the way, and we should make clear that what is written in genes is not set in stone. We can influence our health by making better choices, and that's where personalized nutrition matters. When it comes to the fear of failure, the recommendation is similar to the one above. And when it comes to public versus commercial offering, even if your personalized nutrition offering is of commercial nature, make sure to give examples of specific government or education or health institutions that are introducing or supporting personalized nutrition services. So this was in principle our learning from studying consumers in 9 European countries on how to communicate about personalized nutrition. But the question that I started this presentation with was why communication matters. And I'm not only talking about the communication on personalized nutrition, I'm talking about the science communication in general. Woohoo, barely visible. Okay, so the environment that we live and operate today is defined by media hypes, by buzzwords, by increasing consumers' confusion. Also, the dietary guidelines do not reflect the genetic or cultural diversity. Also, our environment is defined by an unstoppable technological progress that our speakers before have spoken about. There is a vast amount of data produced to be analyzed, interpreted, and applied. And probably the saddest of all, the scientific publications have very limited research. I would like to remind you of a study from 2007, which has shown that 53% of all scientific publications are read by the author, the editor, and the reviewer only. And I believe it's not our aim to communicate to 3 persons, one of us is ourselves. So it is our responsibility to get our work heard of. And also our environment, especially in the world of personalized nutrition, is defined by ethical issues and by policy and regulatory hurdles to overcome. What we want to do is to halt the rise of obesity and non-communicable diseases. What we want to do is to increase the awareness of personalized nutrition and to apply the results of scientific research. And what we want to achieve from the business perspective is to get more market power and improve the reputation of personalized nutrition offerings. And in order to do so, we need to be able to reach the general public directly, or to use trusted channels like health professionals, like educators, like physical activity professionals to amplify the messages to consumers. And we also want to, one way or another, directly or indirectly, reach the policymakers. And that is where communication makes a difference. That is where you need to provide balanced, science-based information, such that people can understand. That is where we need to tailor our materials to different audiences, and that is where we need to use different communication channels to target different types of audiences. And that is where organizations like the one I work for matter, and that's where I will introduce you to EUFIC. So we have 1.25 website visitors per month, meaning that 1.25 million people are exposed to nutrition education and nutrition information in 11 European languages. Russian is not there, so make sure to change that in the future. We have 47,000 stakeholders, among which health professionals, educators, policymakers that receive EUFIC newsletters. And we have communicated and spread information about 22 EU-funded projects so far at eufic.org and at EUFIC social media platforms. But it is not only EUFIC and the organizations like EUFIC that could make a difference. It is you. And science will not make a difference unless it's understood and applied. So I would like to urge you to communicate about what you do in such a way that people can understand. I would like to ask you to go out and speak about what you do. Use social media. Young people follow it. Old people follow it too. So my message for you today is that the only way to make a difference is to communicate about what you do. Thank you.
That's about the patient compliance. How it was controlled in the study?
Patient compliance in this study. So the patients were not really followed very intimately as in the case of Jim Kaput's study. The compliance was in a way just measured by the readings of blood metabolites, but we could not ensure the patient's compliance. We did have physical activity monitors, so we knew about their physical activity, and we could, based on the changes in blood metabolites, assess the compliance.
So how was genetic testing? How did participants get their results? Just the report or with the genetic counseling?
Okay, so what they received was a report with very detailed explanations on how does those genes matter. What do those gene expression levels mean?
They just
for them?
read something themselves without genetic counseling.
They were not exposed to human beings.
Okay, thank you.